to present the case of a 71-year-old gentleman who, okay, here we go. So a 71-year-old gentleman who is a disabled veteran with insulin-dependent type 2 diabetes and end-stage renal disease, secondary to diabetic nephropathy, who's been on intermittent hemodialysis since 2017. He also has proliferative diabetic retinopathy, for which he received PRP bilaterally in 2012. He also has age-related cataracts, for which he had a cataract extraction and a lens placed on the right in 2016. Also in 2019, vitreous hemorrhage, he received vitrectomy and PRP as well. And for the past month, he's been experiencing headaches and left orbital pain and redness concurrent with the same time that he's been receiving hemodialysis. But his dialysis has otherwise been uncomplicated since 2017. And as you can see in the last bullet here, he also has a very significant history of cardiovascular issues. So just to walk through the timeline step by step, he was seen in June or July after receiving the PRP in June. And at that time, he had a stable exam. His vision was 20/30 on the right, 20/40 on the left, and his pressures were within normal limits at 17 and 16. In January, he was seen for a cataract evaluation, and his vision was 20/20 on the right, 20/60 on the left, but he was PAM to 20/20, and his cataract had progressed on the left at that time. Pressures were good, but the cataract surgery was deferred because he was scheduled to have a TAVR done in February. So about 3 months later, he called into the clinic and presented with photophobia, redness, and a deep ache that it was happening in his left eye, which he had said had been worsening for the past week prior to that. His acuity was 20/150 on the left at that time, and his intraocular pressure was 36. So I believe Dr. K was the doctor on call that day. She saw him and noted on exam that he had neovascularization of the iris and angle, and she made the diagnosis of neovascular glaucoma. So he was started on Cosopt and Alphagan at that time. He was seen again about a week later for an evaluation of his retina by Dr. Batra, I believe. He noted that he had vitreous hemorrhage at the time, and he received injection of Avastin. Vision was 20/60 at that time on the left, so it returned back to the value he had in January, and his pressures were back within normal limits. So to give you guys a view of what this neovascularization was looking like on the 17th, hopefully you can appreciate here that there's neovascularization at the pupillary margin here and here. And you can see it a little bit better with the slit lamp lighting that area. Also, if you look at towards the limbus, there's also 360 degrees of neovascularization of the periphery of the iris as well. So on 4/22, his dialysis was ongoing at this time. So at 4/22, he called the clinic reporting that he has this baseline headache for the past month or so since starting a new home hemodialysis regimen, but that his pain was increasing up to an 8 out of 10 during the treatments. So he came into the ED later that day. His pressure was 27 on the left, and his visual acuity was only hand motion on that side. So he was started on acetazolamide. Something that should be noted here is with a patient with end-stage renal disease, prescribing acetazolamide does run the risk of creating a metabolic acidosis. So that's something that should be kept in mind when maximizing medical therapy in this way. He was still on Alphagan, still on Cosopt, and was seen the next day. He was able to count fingers on the left, but his pressure jumped up to 39 on the left. He still had the vitreous hemorrhage, and there was a subjective afferent pupillary defect as well on that side. To give you guys a view of what the OCT looked like at that time, you can see on the right eye here that the angle is open, so that we can assume that there's a patent outflow tract here. But on the left eye, the angle's closed. So that's where that neovascularization of the angle is coming into play. If the apparent nature of those vessels are beginning to pull traction on those tissues there, it can actually close that angle. So the question at this point is, can dialysis elevate intraocular pressure? And this is a phenomenon that was first studied back in 1964 by a team out of Denver. And what they found was that in 89 of the patients that they studied, they saw that 83 of them had increased intraocular pressure during hemodialysis. I'm not sure if they are using, at the time they were using tonometers that were still being used today. I think there was a Schiatt's tonometer and a Maklakov tonometer, which I hadn't heard of, but they measured that between 4 and 8 millimeters of mercury jump that they observed during dialysis. But those returned to normal values within 2 to 8 hours following treatment. The relationship's not fully understood, and since then, multiple studies have looked at this, and some have shown that there's increase, some shows decrease, some shows no change whatsoever. So there is quite a bit of equipoise there. The proposed mechanism is that during hemodialysis, when the osmolarity of the plasma is dropping quickly from the urea being removed, that leaves the aqueous hypertonic to the plasma, and that gradient allows water to flow into the aqueous, increased aqueous production. And for patients who have an outflow tract that's normal, they can usually withstand that pressure change. But for someone like our patient with a closed angle, you'll see those increases in IOP. So one of the things that can be done is modification of the dialysis to try to change the rate and magnitude of osmolality changing, so to reduce the gradient as much as possible. So what was done for our patient is the sodium concentration was increased of the dialysate, and also the blood flow and dialysate flow were decreased, and the duration of dialysis was decreased. So the idea is, by adding sodium into the dialysate, hopefully the osmolality of the plasma and aqueous would be more closely matched during treatment. And by running the dialysis at a slower rate, the gradient wouldn't be created as quickly, giving the eye more time to equilibrate. So some of the other strategies can include infusing effective osmols like mannitol or hyperosmol or glucose. Also, I believe only in animal models so far that increasing ultrafiltration has been tried, so that you can increase the plasma colloid oncotic pressure. So by having a higher protein concentration in the plasma, you can help pull back some of that fluid into that compartment. So our patient was placed on this modified dialysis regimen. He's on maximal medical therapy at this point with acetazolamide, alpha-GAN, and COSOPT. And you can see here on the 25th that the pressures in the left eye were within normal limits before dialysis at 12. But 3 hours in, he was measured again, and it more than doubled to 25. 4 days later, he came back for another round of dialysis, and he was still elevated. He was still at this baseline, this new baseline elevation, matching the previous elevated IOP, and then even picked up an additional 8 millimeters of mercury 3 hours into dialysis. So at this point, the decision was made that a surgical intervention was necessary, given that he was already on maximal medical therapy and still IOP was not well controlled during dialysis. So Dr. Steffen and Dr. Batra came up with a plan to work together, and a combined operation was done on 4/30, where cataract was removed on the left and he received an intraocular lens. Dr. Steffen performed that. Then Dr. Batra tagged in and did a pars plana vitrectomy with PRP, and then Dr. Steffen tagged back in and placed an Ahmed valve. So on postoperative day 1, the patient was able to count fingers at 5 feet. His pressures looked great at 10 and 7, and the lens placement looked good. And at that time, he was scheduled to return to clinic in 1 week, which I believe maybe today. So it's possible if Dr. Stefan or Dr. Batra is on the phone, they may have an update to give at some point on the patient. So to talk about some similar cases in the literature, last year, Lippold presented a case of a 72-year-old male with end-stage renal disease who was on an in-center dialysis for 1 year. And very similar to our case, he was experiencing increased IOP, periorbital redness, pain, swelling during hemodialysis. They started to give him latanoprost, brinzolamide, and brimonidine, but they stayed away from beta blockers because he was also a COPD patient. And they adjusted his hemodialysis regimen with some success, but his IOPs were still above where they wanted it to be, so they ended up performing cyclophotocoagulation. But the interesting thing about this study is that they coined the term ocular dialysis disequilibrium for this phenomenon, similar to the disequilibrium that can be seen with urea during dialysis. So also last year, Babaker presented a case of a 63-year-old male with type 1 diabetes and ESRD with proliferative diabetic retinopathy and neovascularization of the iris, who received PRP for that. They were also experiencing spikes of symptomatic elevated IOP during hemodialysis. They tried topical antihypertensives, but that failed to lower the IOP, and he was too unhealthy for them to attempt IV mannitol or glucose or any acetazolamide. So he ended up getting a trabeculectomy with mitomycin C, and that was able to achieve good control of his IOP. So to talk about some of the risk factors that are associated, anything that has the potential to obstruct the aqueous outflow, like pre-existing narrow angles, angle closure glaucoma, pseudoexfoliation, or uveitic glaucoma, that's something that should be a red flag and should bring to your attention that this could be a possibility. Other conditions are things that can cause neovascularization in the eye, such as ESRD or diabetes or vasculopathies. So some of the key takeaways are any ocular pain or visual changes that are noted during dialysis should warrant ophthalmic investigation. Any patients with angle closure, like was said earlier, should be a red flag. And diabetic neovascularization can progress in eyes even after receiving PRP. So it's not something that should be done on a chart review and seeing that a patient has PRP, but assuming that they can't have neovascularization in a situation like this. In closure, I'd like to ask some questions of the audience to stimulate some thought here. How prevalent could this phenomenon be if the connection is not well known by either nephrologists or ophthalmologists, that there's this potential for dialysis to affect intraocular pressure? And should we be studying this phenomenon prospectively rather than through case studies and case reports? And should practice guidelines be updated? Should risk calculators be created? Should we be screening patients for elevated IOP during hemodialysis if they have some of these known risk factors? So with that, I will conclude, and thank you for your time.
Excellent overview, Chad. Thank you so much. I personally didn't know that this was a possibility. And I know I don't see these patients regularly, but I do take call, and so it's just helpful to know that that could be a question you'd ask about their history, about dialysis. So very educational for me.
Thank you.
Chad, I hope you can hear me. The excellent presentation. Unfortunately, the patient is returning at 8:30 tomorrow morning for his 1-week post-op. We didn't get a chance to see him today. So I don't have an update on his status, at least not tonight.
Well, hopefully, if we're able to get that abstract submitted by the end of the month, we'll have some good information to add in there to whatever we submit.
Yeah, we should hopefully have plenty of follow-up visits before then, but unfortunately, I don't have one on his 1-week status yet.
All right. Thank you.
Hi, Chad. This is Martha Graber. I thought that was really, really excellent. This is not a problem that we're aware of as nephrologists. And we experience a lot of patients that have headache after dialysis. or during dialysis, and that it's, as far as I know, in the textbooks, not listed as part of the differential diagnosis. So this is definitely an under-recognized phenomenon. We will have some he's gone back home to do his home dialysis, but he's going to come into the clinic in a couple of weeks to do a run of dialysis, and we'll be able to do a post op check of his intraocular pressures on dialysis.
It's great.
I thought that was terrific.
Oh, thank you. I appreciate it. Thank you for your help with developing this presentation too. I really appreciate it.
The studies that you were reporting, are most of them in the nephrology or ophthalmology literature?
There's a bit of a mixture, and I can advance the slide here too to show some of the papers that I cited. I actually have amassed quite a bit more articles than this in the initial literature review, but a lot of them are coming from hemodialysis journals or ophthalmology journals. I believe that a handful of them are from nephrology journals so far, but I've managed to get about 40 or 50 papers. I haven't made it through all of them yet, but there are very few cases of this that have been reported. And I think one of the things that makes this case a little bit unique is the neovascular glaucoma angle as well.
That brings up, this is Donald Miller. It brings up things to study is how long in an otherwise open angle does the IOP elevation last in a typical open angle if people get elevations of 3 to 5 points.
Right. In the initial study that was done in 64, that the range was from 2 to 8 hours before people return to their baseline IOP. But since then, people that have tried to recreate the study, I think in healthy architecture with a normal outflow tract, there's actually a decrease in IOP that's seen. So it's really the major issue is with people who have closed angles or some type of outflow obstruction.
It almost seems like the nurses in the hemodialysis center should have a tonal pen and at least be aware. And if they have a patient who's having eye pain, that they feel comfortable checking the pressure, perhaps.
Right. Yeah, that is something that Dr. Stefan and I were discussing the other day. Is what would be the feasibility of training people how to measure this IOP during dialysis treatment, so that ophthalmologists wouldn't need to be called to the floor if there was an issue like that. And I'm curious how the data would pan out if this was something that was measured more often, if there would be any surprising patterns that would come out.
Hi, this is Martha again. I think that's really a great question. It's a great project for renal fellows, but it is something that could really be, I think, relatively easily brought into clinical practice, because there's a very stereotyped way that patients are prepared for dialysis by dialysis technicians and taken off dialysis. So this is something that I think it would be realistic to incorporate, certainly in selected patients.
That would be great. I don't think that there's any studies out there that have done anything that extensively. So if we were to do a study like that, I think it would definitely contribute to the existing literature significantly.
Thank you so much, Chad. Really excellent presentation. Excellent.
Great. Thank you so much.
Yeah. So we should move on to Dr. Kanagalingham's presentation.